name is Dr. David Stewart. I'm a medical oncologist in Ottawa, Canada, and a professor of medicine at the University of Ottawa. And I recently wrote a book on cancer called A Short Primer on Why Cancer Still Sucks, available through Amazon Books. There are different ways to make decisions on approving and paying for new drugs. We do not want to keep drugs that are ineffective, but we do not want to throw out drugs that are effective. But there's a lot of imprecision in measuring drug benefit and differences in opinion on what's the best way to make a decision about whether or not a drug is effective. In this video, I will give my personal perspective on this. In a previous video called How Common Sense Oncology Defies Common Sense, I discussed how many oncologists regard the gold standard for deciding a drug is effective is a statistically significant improvement in life expectancy or overall survival with a new drug. In that video, I discussed how they would probably rarely approve a drug that was ineffective, and that is good. But they would be at high risk of discarding effective drugs because of the impact of things called crossover and post-progression survival on overall survival metrics, and that is bad. If even a fairly low proportion of patients on the trial's standard therapy arm cross over and receive the new drug when their cancer gets worse, that makes the control arm or the standard therapy arm look better than it really is. So that reduces the apparent overall survival difference between the new therapy and the standard therapy. This makes the new therapy look ineffective simply because it's of benefit in the people that crossed over to it from standard therapy to the same extent that it's of benefit in the people that started out on it. We found that if as few as 20% of patients on the standard therapy arm cross over and receive the new drug at tumor progression, this cuts in half the probability that the overall survival gain will achieve statistical significance. Post-progression survival means duration of survival after the patient's tumor begins to grow on the initial therapy. So because of the way that statistics are calculated, the longer the post-progression survival, the lower the probability that the apparent gain in efficacy or in survival with the new therapy will achieve statistical significance. And this will happen even if the gain in overall survival is quite substantial. This means that using the overall survival gain as a metric to decide whether or not to keep a drug increases the probability of discarding an effective drug if one requires a statistically significant improvement in overall survival to keep the new drug. If those paying for a new drug base their decision on the gain in overall survival, it also increases the probability that those deciding to pay for the drug will decide not to pay for it if they base their decision on such an unreliable metric. Science is like a giant jigsaw puzzle. There are only a few pieces in place, and we try to draw conclusions from those pieces that are in place. Stating that we have a gold standard means that we think we already know what the puzzle's about, and we're going to throw out any pieces that do not agree with our preconceived notion about what the puzzle shows. Relying on a gold standard makes it easy to get things wrong, just like relying on the gold standard of an overall survival gain as a metric to decide on whether or not to keep a new drug will mean that we will often make the wrong decision. In the earlier video, I've stated that the time to tumor growth, or so-called progression-free survival, may be a more reliable metric of the drug's benefit than is the overall survival gain, because unlike overall survival gain, it is not impacted by crossover or by post-progression survival. Progression-free survival gain is no more a gold standard than the gain in overall survival should be, but it's another piece that is added to the jigsaw puzzle that helps us make decisions about whether or not a drug is effective. And we need to consider all the evidence and not just an unreliable gold standard. I stated in that video that there are also caveats and limitations in the use of progression-free survival as an indicator of drug benefit. And in this video, I will discuss some of those caveats and limitations. The first caveat is in some cases, the progression-free survival gain may be statistically significant despite being small and clinically unimportant. To assess this, we analyze the ability of the progression-free survival gain to predict the overall survival gain in studies in which the progression-free survival gain was statistically significant and the overall survival gain had not been distorted by more than just minimal crossover. Most clinical trials use median values in judging the duration of progression-free survival or overall survival. The median is a point at which 50% of the patients have either progressed or died. One issue with medians is that they are derived from survival curves that are quite bumpy and that deviate back and forth a lot. If the survival curve deviates to the right or left right at the midpoint, this can misleadingly make the survival look either higher or lower than it actually is. So instead of using medians in our academic publications on this, we instead used half-lives. And as we discussed there, half-lives can be easily and readily calculated by just about anybody using readily available software. Like a median, the half-life is the time at which about 50% of the people have either progressed or died. But unlike medians, it is not derived from the survival curves themselves. Instead, it is derived from a regression line for the log linear plot of the survival time. Since this nonlinear regression line is smooth, it removes the variations in survival curves that make the median calculations much less precise. The value for half-lives for a curve are very, very similar to the value of medians, and they correlate with each other very, very strongly. But in our experience, half-lives are more reliable than medians because they are impacted less by random variation at the midpoint of the curve. What we found in studies where the overall survival measurement was reliable, since there was very low crossover, was that a statistically significant improvement in progression-free survival half-life of 1.5 months or longer had an 80% probability of being associated with an overall survival half-life of 2 months or longer. And in many cases, with a progression-free survival gain of 1.5 months or longer, the overall survival gain was much higher than that. On the other hand, for most therapies, progression-free survival gains of less than 1.5 months were likely to be associated with an overall survival gain that was less than 2 months. The higher the progression-free survival gain, the higher the overall survival gain on average. So that, for example, with a progression-free survival gain of 5 months or longer, there was an 80% probability that the gain in overall survival would be 6 months or longer. So the first caveat is to consider both the statistical significance and the size of the progression-free survival gain, and not just the statistical significance of the gain. The second caveat is that while progression-free survival half-life gains were reliable in predicting overall survival gains, the gain in progression-free survival median values, a more common way of measuring it in the past, they are much less reliable because of the imprecision in determining medians. But half-life gains are reliable and they can be calculated very easily and rapidly. The third caveat is that improvement in progression-free survival did not predict an overall survival gain in all situations. Specifically, it did not predict it well with prostate cancer, metastatic prostate cancer, or with particularly toxic high-dose therapies. The reason it did not predict it well with prostate cancer is that prostate cancer frequently is metastatic to bone, and bone metastases are very difficult to measure and to assess precisely. It did not work well specifically with 2 studies of high-dose therapy, one with bone marrow transplant and the other with high-dose interleukin-2. And our thinking here was that it most likely did not work well there because it might prolong progression-free survival, but because of the toxicity of the initial therapy, if the patient's tumor worsened, they would not be able to tolerate subsequent therapy, so post-progression survival would be very short. If we exclude these 2 prostate cancer studies and these 2 studies of high-dose toxic therapies, then progression-free survival gain became an even better predictor of overall survival gain. Overall, if there was a 1.5 month or greater improvement in progression-free survival, then that was associated with a 90% probability that the overall survival gain would be greater than 2 months, and a 98.4% probability that there would be at least some gain in overall survival. What this means is that if the gain in overall survival is unreliable because of crossover or long post-progression progression survival, then the gain in progression-free survival would give us a reliable indicator of what the true improvement in overall survival is likely to be if it was not distorted by these other factors. The fourth caveat is that we only tested this method in patients with solid tumors treated with systemic therapies. So we did not test it in hematological malignancies like leukemias and lymphomas and myeloma. The fifth caveat is about something called hazard ratios. Simplistically, hazard ratios are calculated by dividing the number of patients surviving in the standard therapy arm at each time point by the number of patients surviving in the experimental therapy or the new therapy arm. And the smaller that number is, the more favorable it is, and the higher the probability that it will be statistically significant. However, hazard ratios are typically much more favorable with progression-free survival than with overall survival because of the impact, the negative impact on post-progression survival on the hazard ratios for overall survival. However, the overall survival hazard ratios are usually much less favorable than the progression-free survival hazard ratios because of the impact of post-progression survival on the overall survival hazard ratio. Therefore, progression-free survival ratios do not do a very good job of predicting overall survival hazard ratios, but the gain and progression-free survival does do a good job of predicting the gain in overall survival. The sixth caveat is that the gain in progression-free survival may be statistically significant, but the gain in overall survival may not be statistically significant even if it is quite large, and this is because of the impact of post-progression survival on the statistical calculations with overall survival. The lack of statistical significance of overall survival does not mean that the benefit of the drug is not real. The statistical significance of the progression-free survival gain indicates that the drug probably really is having a real biological effect against the cancer. The relationship across trials between gain in progression-free survival and gain in overall survival tells us with 90% confidence that there really is a gain in overall survival, even if it is not statistically significant. The seventh caveat is if there is too long a time interval between follow-up scans for patients on the trial, then early progression may be missed, and this may artificially lengthen the apparent progression-free survival time. So we need to consider the frequency of follow-up scans when we're assessing progression-free survival, particularly in trials where it's quite short. The true progression-free survival may be shorter than what is measured if the frequency of follow-up scans is not frequent enough. The eighth caveat is if patients go off the clinical trial early for reasons other than tumor progression, this may lead to inaccurate conclusions due to something called informative censoring. The fact that progression-free survival gain was such a good predictor of overall survival gain across a wide range of trials means that for most studies, the frequency of follow-up scans and the informative censoring are not major issues. The ninth caveat is if you set your progression-free survival bar high, say at 5 months, then the majority of patients that will have that progression-free survival gain of 5 months will have an overall survival gain of 6 months or higher. But there will be some patients with a progression-free survival gain less than 5 months that nevertheless do have an overall survival gain of 6 months or more. So some good drugs may be discarded if one sets one's progression-free survival bar too high in a clinical trial. On the other hand, all the drugs that we assessed that did have an overall survival gain of 6 months or more did have a progression-free survival gain of at least 1.5 months. And therapies with a progression-free survival gain of 1.5 months or more, 48% had an overall survival gain of 6 months or more. So a high progression-free survival gain does predict a high overall survival gain, but you also have to look carefully at any drug that gives you a progression-free survival gain of 1.5 months or more. My 10th caveat is that some drugs might have a statistically significant impact on overall survival, despite having a non-significant impact on progression-free survival. However, the only class of drugs that we found that this happened with any frequency was what are called immune checkpoint inhibitors. With immune checkpoint inhibitors, overall survival gain frequently substantially outperformed progression-free survival gain. The reason this happened is uncertain. Some people have hypothesized that the immune checkpoint inhibitors may lead to an added immune effect after the drug is discontinued. And this is possible, but we don't know the mechanism by which this would happen. The other possibility is that it is a statistical glitch related to the way in which we calculate statistical significance. In some specialized analysis of progression-free survival curves, we found evidence of two distinct subpopulations in patients across a range of tumor types treated with immune checkpoint inhibitors. One subpopulation is as if you're just giving them a placebo, whereas the other subpopulation is giving them a very highly effective drug. This difference that we saw with one subpopulation behaving as if they received placebo and the other behaving like they received a highly effective therapy is different from what we saw with other therapies. And it's possible that this is actually affecting the shape of the overall survival curves and the statistical significance of them. We plan to do some further mathematical modeling of this to determine whether this could be the case or not. My 11th and final caveat is that we also need to consider response data in addition to progression-free survival and overall survival data. We need to look at all the data that's available in judging whether a drug is effective or not. In summary, when we're assessing the efficacy of drugs, we need to look at all the data available and not just potentially unreliable gold standards. But no matter how we look at the data, there's always going to be some uncertainty, and we cannot necessarily rely on just a single metric. Thank you.